Good morning. I think I've been a little bit more anxious about this group than the oral session later today at 4, so wish me well. Thanks for asking me to speak for my fellow investigators about this phase 1b study of Vadastuximab Talirine, I'll call it 33A, in combination with 7+3 induction chemotherapy for newly diagnosed AML patients. So let's put this in perspective with some background. In 1973, 43 years ago, the first paper was published on what we still continue to use as the initial therapy for a very aggressive cancer, acute myeloid leukemia. And it was a combination of 3 days of an anthracycline drug and 7 days of cytarabine. And we call it 3 and 7 or 7 and 3, depending on which institution trained you. And nothing has been shown yet to be superior to that, despite 4 decades of clinical research. We can cure some people with this regimen followed by post-remission treatment. What we've learned more recently is the depth of the remission after that initial treatment may predict for a better outcome, a better survival. So not only not seeing the disease under the microscope, but using very sensitive tests for minimal residual disease. These have not been standardized yet. They're not used commercially in practice. These are research tools, but things like flow cytometry, next-gen sequencing, this kind of data has shown us that the deeper the remission after the induction, the better the outcome for patients, which will lead to the hypothesis that if we can change in some way the induction therapy to get a deeper remission that we'll call an MRD negative or minimal residual disease negative state, that this may ultimately lead to an improved outcome for patients. Now, before we did this study of Vadastuximab Talirine, there had been a prior drug on the market that you may have heard of, Gemtuzumab ozogamicin, which had the trade name Myeloid. It is also an antibody drug conjugate. It is targeted to CD33. CD33 is an antigen. It's a marker that's found on the outside, on the cell membrane of leukemic blasts from over 90% in about 90% of AML patients. So it's expressed in the majority of patients with AML. There have been randomized clinical trials from Europe, the MRC in the United Kingdom and France, that have shown improved outcomes with the addition of Gemtuzumab ozogamicin to intensive chemotherapy. And the Children's Oncology Group here in the United States showed a lower risk of relapse, a better relapse-free survival for children who had Gemtuzumab ozogamicin incorporated into their regimen. And so there's some historic precedent in the literature that suggests that adding an antibody drug conjugate may improve outcomes, and we hypothesize this might be by giving a drug that can lower the amount of residual disease after the initial induction. So we conducted a phase 1b study, and these slides are not going to talk much about the dose escalation. We treated, but I'm happy to answer those questions. We treated 42 patients in the study, and these were adults up to the age of 65, AML excluding acute promyelocytic leukemia, which you know is treated with arsenic and all-trans retinoic acid. They couldn't have had prior therapy for AML, but secondary acute myeloid leukemia, AML arising from myelodysplastic syndrome, was allowed. The patients received this antibody drug conjugate 33A in combination with 7 and 3 on the first day and the 4th day of that 7-day regimen in a 28-day cycle. And then responses were evaluated by bone marrow aspirates and biopsies at day 15 and 28, the way we normally do with this intensive chemotherapy regimen. A second induction regimen and post-remission therapy were according to the investigator's choice and did not include CD33A. About half of the patients, in fact exactly half, 21 out of the 42, did go on to get an allogeneic stem cell transplant. The key study objectives were to evaluate the safety and tolerability, to establish a maximally tolerated dose of this antibody drug conjugate in combination with our standard therapy, and in a preliminary way to assess anti-leukemic activity. So there were 42 patients. The median age was 45 and a half years old, but we treated people up to the age of 65. You could see they either had to have an ECOG score of 0 to 1, which means that they spent very little time in bed or sitting around. They can do most of their normal daily activities. 17% had secondary AML, 50% had intermediate risk karyotypes, and 36% adverse karyotypes. We know this is a very important prognostic factor for remission rates, but more importantly, long-term survival. Only 10% had nucleophosmin mutated disease, and 14% had FLT3 mutated. A little bit lower than what we would expect. About half of the patients with the normal karyotype would have a nucleophosmin mutation. So if you say 50% had normal karyotype roughly, 50% of them would have nucleophosmin. That should be about 25%, a little bit lower. And the FLT3 mutated, again, that's about half of what we would expect in a previously untreated population of patients. We don't have, obviously, an explanation for this, except for the possibility that at the same time this study is running at the 14 centers that conducted this study, we also had competing trials that specifically were looking at FLT3 inhibitors. And so it's kind of an interesting topic for the future of how, as we parse out this disease, how do we study the efficacy of these different regimens? Now, every patient treated with intensive chemotherapy for AML develops grade 4 neutropenia. That's a neutrophil count under 500, at which they're at risk of infection, and a platelet count under 25,000, grade 4 thrombocytopenia. But some patients started the study without those things, and the top part of the panel there shows you the incidence of developing grade 3 or 4 cytopenias while on the study if they weren't present at the beginning. And there's nothing really surprising there. I mean, the entire regimen as a whole is myelosuppressive. What we need to talk about is it more myelosuppressive than just 3 and 7 alone. In terms of the non-hematologic toxicity, they're mostly grade 1 and 2, milder toxicities, and very similar to what we would have seen if a patient was receiving 3 and 7 alone. Now, because gemtuzumab azogomycin was associated with the risk of liver toxicity, I'm pointing out here that only 1 out of our 42 patients had a grade 3 elevation in ALT or AST. That's 5 times upper limit of normal. So here's the efficacy results. 76% of our patients achieved a response. Most of those were complete remission, meaning the neutrophils recover over 1,000, very important for preventing infection, and platelets recovered over 100,000. 17% of those of the total had a CRI, which were all due to the platelets not recovering to over 100,000, very similar to what had been seen with gemtuzumab azogomycin. And then you see the breakdown according to the cytogenetic risk group, a lower overall response rate in the adverse, the 15 patients with adverse karyotype. However, I think it compares favorably with what we might expect in that from historical controls for that cytogenetic group. So overall, a response rate of 76%, not too dissimilar to what we might expect for a well-chosen population of patients who are fit for a clinical trial. Not really different. So why are we getting excited about this? Well, as I said, there's the historical data with gemtuzumab suggesting that this really may lead to something, but there was a hint from our study that this may add benefit. And the first hint was that 30 out of the 32 patients only required, to achieve that remission, only required 1 round of chemotherapy. Now, that might not be something that leads to FDA approval, just that fact, or a registration, but it's really important for a patient who really cares about the difference between being in the hospital for 4 weeks versus 6 to 8 weeks if they get 2 cycles. It also suggested, though, that we might be getting deeper remissions. And so we did an exploratory analysis, a correlative study here. We used a very sensitive flow cytometric assay done by one of the international experts on using flow cytometry for looking for minimal residual disease, Brent Wood at the University of Washington. And what we found was that 25 out of those 32 complete remissions, so just over 3/4, were actually complete remissions that were MRD negative. So going back to our hypothesis, if we can get patients into an MRD negative state, maybe the outcomes would improve. And later today, I'll present some comparison with another data set suggesting that that rate of minimal residual disease may actually be better. So in conclusion, what we felt we showed was that we were able to combine active doses of 33A with 7 and 3. The doses here were less than the dose used as a single agent, but all doses in our phase 1b study, including lower doses than what we actually used here, showed complete remissions as a single agent. So they are effective doses of 33A, and it added acceptable on-target myelosuppression. We saw platelet counts recovering over 100,000 and neutrophils over 1,000 by about 4.5 to 5 weeks, which we felt was reasonable, and patients were able to go on and get post-remission therapy. The non-hematologic toxicity was similar to 7 and 3 alone, and again, hearkening back to gemtuzumab, we didn't see any veno-occlusive disease or sinusoidal obstructive syndrome, and only one patient with reversible grade 3 hepatic toxicity. And there was a very low 30-day mortality of 2%. There's also preliminary evidence of added activity, not just the response rate of 76%. You could argue that that's not really dissimilar to what we might expect. But the responses were rapid, achieved in most patients with only one cycle, and 78% were deep remissions that were MRD negative, which we are hoping will translate into a real benefit for patients, which obviously will only be able to test in the setting of a randomized trial, which is planned to start in the first quarter of 2017, comparing 7+3 versus 33A with 7+3. We're also still exploring in this phase 1b study just a single dose on day 1. Thank you.